Can you see my slide now?
Yes, yes, yes.
Okay. So I'd like to thank the Jaipur Ophthalmic Society, Vishal, Dr. Virendra, Dr. Rakesh Sharma for having me here. It's been a wonderful experience so far. And so when we talk about TRDs, there's always this debate about unimanual versus bimanual. Personally, I think there's actually no debate there. I mean, you have to customize it. You have to be skilled with both approaches and hybridize it. So I like to get, when the view is clear, a good preoperative OCT, and that helps in your decision. And when you see a taut hyaloid, thick membranes with focal tractions, like you see on the left here, or with detachment, or with schisis, then given the fact that we have such good cutters, especially the bevel cutter from Alcon, and port optimization, you can go a long distance with just unimanual vitrectomy, and you can actually use these planes of attack. On the other hand, if you have a broad attachment, tabletop TRDs like these, then you know you have to favor bimanual vitrectomy fairly early on, and these would be the planes that I would attack. Now, recently I've been using multicolor imaging a lot more to look at these TRDs. The fibrosed hyaloid shows up in green. You can actually make out the avascular versus the vascularized components, and you can see those hyaloidal openings, which are very important. It's important to know these planes, and you can take advantage of that. And I usually, in this particular case, I had actually gone like that, avoiding those vascular areas. And you can see it's far better than the fundus picture that you see on the right of the MCI, and you can see post vitrectomy a fairly good result, and you can even image this through the oil, multicolor imaging. So coming on to unimanual surgery. So again, there's this debate about should we do inside out or outside in. Again, you should be able to customize your surgical technique to the case in front of you. And for example, I more often than not use inside out, simply because the central retina is thicker, and very often you have the mid-peripheral vitreous well attached to the mid-peripheral retina. And in this case, you see that there is a central taut hyaloid with the subhyaloid space available, and do a canopner kind of opening of that hyaloid, and then in that central rent, proceed radially or centrifugally, identifying the plane of separation, slightly tug on that, not too hard, and undercut. It's important to have your port facing away from the retina. Another case where one doesn't have that advantage of that subhyaloid separation from the macula, so you can choose a weak spot in the taut hyaloid or membrane, create a rent there, again proceed radially using the conformal techniques of membrane peeling that I'll be talking about a little later. Again, undercut it, identify the plane of separation, and that is critical. Now, this is a case where an outside-in approach is useful. Here you see very clearly that the mid-peripheral vitreous is detached from the mid-peripheral retina, so you can excise that skirt in a latitudinal manner, freeing that central island of taut hyaloid that you see. This has the advantage of avoiding transmission of the central membrane peeling traction forces to the periphery and causing holes therefore. So you again identify the plane of separation and go from outside in, undercutting that membrane. Another case which kind of brings it all together, the patient had a hemorrhage and then traction under that, so I'll just go past that quickly. And with the cutter, I like to engage the vitreous membranes and what I call tug and tease, and creating small microtractions, creating these BR separations as you go along, as you engage that hyaloidal layer. And this patient had some amount of peripapillary traction too. So you can see I'm trimming around the disc in a little while. You have to isolate the traction from the disc, and going ahead in that manner and using techniques of conformal and fold back membrane removal. If there are bleeds, you can diathermize or laser. If it's atrophic retina, definitely do avoid diathermizing. A gentle laser will do in most cases, more often than not. And another case which, again, there is a very thick taut central hyaloid, there's subretinal hemorrhage there too. Again, what this shows is that you don't actually have to remove unmask the entire traction, you just have to segment it into islands. And the cutters nowadays do a great job here. And as you can see, I'm bringing, isolating those segments into different islands. And once you segment them, you're quite surprised to see how easily you can, given the port optimization of these new cutters, actually eliminate those segments. This was done with the Alcon Ingenuity system, and under air, the view becomes clearer, or the wispy hemorrhage goes, and you're able to aspirate the hemorrhages also, and you see it looks fairly flat now. And then you go ahead and do the laser around it in the veiling areas. And so cutter delamination of epidermal membranes, there are two types. The more commoner one, the more difficult one is the conformal cutter delamination, where you have rigid ERMs. It's a stiff edge. You need to turn the cutter in your fingers so that the longitudinal axis is aligned to the angle of attack with the desired point of the ERM. The other technique is the foldback cutter delamination, where you have these flexible ERMs with a large free edge, and this folds back over itself, and the ERM therefore protects the retina. So this kind of demonstrates that the conformal technique, where you go kind of parallel to the retina and keep eating it, feed the membrane into that port, and keep going across like that. And you can take that membrane quite easily. And this is a large free-edged membrane, as you can see, and using suction, you fold that back on itself and get that membrane off, as you can see. So just a quick take on a TRD with subhyaloid hemorrhage. This happens quite often. It's very important to make a rent in that posterior hemorrhage. First, choose a locus that's free of traction. Drain the subhyaloid hemorrhage. Do not go in blind, and visualize the vicinity, and then proceed. Just a small note there. Coming to bimanual surgery, this is a very vascular membrane. You can see that it's a very taut hyaloid ring. The membrane is very thick. You need, so straight away you need to know that you need to go with bimanual vitrectomy early on, inside out. The one point I'd like to stress is that the angle of illumination your assistant needs, if you have a good one, focus that cone of light on the area that you're working on. And the curved scissors is a great boon. The 40-degree curvature of the curved scissors parallels that of the retina. Gets into these small spaces. You need to make small controlled cuts, not wide, vigorous movements. This curved scissor is flexible. You can do both segmentation, as I'm doing right now, as well as delamination, as we'll see in a minute. And because of those fine scissors, yeah, here I'm delaminating it. You just twist it in your arm, and you can just do that. And the blades help you to use this also flexibly as a spatula or a blunt dissector. As you dissect those membranes, you can see how thick that membrane is. I use the end gripping or the island forceps to grip and evert that membrane. Remember, right now the forceps use is not to yank or drag that membrane off. It's only to hold it and evert it so that the scissors can do its job. As you'll see in this very interesting case, with where again I'm going in with bimanual vitrectomy, there was a severe peripapillary retraction, as you'll see. Chandelier coming in, and the curved scissor helps in making these small snips. Again, just to stress that the angle of illumination is very important. You have to visualize the exact area that you are snipping, and you have to keep that curved scissors facing up and away from the retina and towards the thing. And you have to, when you cut and make a deliberate movement up and away from the retina, so that you avoid damaging the retina with your cuts. The bleeds may be passive. Don't get worried about that. And intraocular pressure rise, you can just control that. You see, as long as you see that the bleed is not rapidly increasing, you don't have to worry about it. You don't need to go in with the diathermy and do anything there. You can see with that island forceps, it's a used island forceps that I now prefer to use. And now, as I'm grabbing that, you see I'm not exerting a lot of force, but with just that gentle bit, I was surprised to see that stump come out very easily without any vigorous traction on it. And I just went with the flow and then used that forceps to remove the vitreous from the membrane, the retina around, and it just kept going in that direction. And I'm doing that, and you see that the entire thing folds. I'm diathermizing the edges so that it curls on itself and separates itself from the retina, detached retina around. And now the cutter, I'm separating it entirely, and it's now swimming around. It actually looks like a nucleus fragment, and you're seeing that the entire thing is now detached. And I'm just removing the last segments of that, and just taking out those last fibrils, and it's now going to swim on itself. And then you just keep it, and like you would do for a nucleus fragment, just keep it there, and the whole thing, it's such a thick fibrous tissue, just gets eaten up right there. You can see it's getting taken right there. So now I like to do ILM peeling. I feel it should be done when you have residual pucker post membrane peeling. And where I would not do it is if there's severe ischemia or RP degeneration or an atrophic macula, you can actually damage it a little more. So you put in the BBG under a bubble of PFCL, and then you can evacuate the BBG. And then you see that the ILM actually comes out quite easily, counterintuitively, because the counter traction by the PFCL makes the ILM scroll on itself, and therefore actually makes it easier to visualize and grab. So you use the pinch and peel technique, and you see it's quite easy to do it, and it comes off fairly easily. So PFCL use, actually I believe it has a negligible role in TRDs because of the risk of unnecessarily having subretinal PFCL. You just need to remove all the traction. Where it's used as I'm showing here, ILM peeling, combined mechanism RDs, or if there are breaks, if there is a lot of submacular hemorrhage, where you can steamroll out this fluid or the hemorrhage. I occasionally, if there is a lot of blood, I use that to my advantage. If I have to do ILM peeling, I use blood as a stainer. All you need, all BBG does is give you contrast, and blood is doing that, then well and good. Might as well go with that. And you can see once you get that stain, it actually helps you a lot. Once you get that, the first peel off, it's quite easy to complete the ILM peeling. And that's fairly well. So tamponade, the question of tamponade. So what everybody should aim is for no breaks or minimal no bleeds. And TRDs ideally should be left with aerosaline. This should be a goal. But in the case that you do get a couple of breaks or there are minimal bleeds, where you have a fairly flat attached retina, you lasered around those little bleeds, gas can be used. SF6 also is repeat. Silicone oil, only there are significant breaks or bleeds. It's a combined mechanism RD, as I mentioned. A high-risk patient who cannot position prone or is a one-eyed patient, then you might favor silicone oil. Very important, as I'm stressing again, avoid iatrogenic breaks. Why do these happen? That's because some people believe in rapid vigorous PVD induction. They see the thick membrane, they believe they need to pull it, yank it out. That causes this. Again, exclusive unimanual cutter-based vitrectomy for tabletop TRDs or adherent taut hyaloid membranes to atrophic ischemic retina. When you see that, that it's better to go through the bimanual scissor-based approach. Many people have a prejudice against scissors. Once they have a great cutter, they think they can use the cutter for everything and complete extension of scissor use. So all these things can actually lead to having unnecessary breaks, which should be avoided. So basically, the cardinal principles: visibility is king. You have to have a good illumination system and a good viewing system. There's no doubt about that. You have to have primarily one with given the great cutters that we have. Unimanual we would go in with, and I would fall back on bimanual immediately if I see those tabletop TRDs, or as I showed up front to the OCT. You need to be skilled with both inside out and outside in approach. You should be able to customize and be flexible in your approach. The great bevel cutters which are coming in now from Alcon, the 10K, 20K cutters, it's a bevel more than the 10K, which I like because it gets you into those small spaces. Please find those VR separation planes. That is the key to TRD surgery. Importantly, try to avoid breaks. Beware of vitreoschisis, which happens in these cases. It's a good idea and good habit to do repeat triamcinolone stain check to look for this, because residual vitreous can lead to ERMs and can lead to failure of surgery. Membrane peeling, removal, curved scissors are great. As I mentioned, the 40-degree curve helps you get to both the segmentation and the delamination. It also parallels the curve of the retina. The techniques of confocal and fold back, as I described, need to be used judiciously. Bleeder control with IOP rise. Laser is a better option than diathermizing around the area centralis. Triamcinolone clots can sometimes be left over little bleeders, and you'll be surprised that they actually stop. Preoperative Avastin is a great thing and should be done for TRDs with active neovascularization overlying it, and this should be done about 3 to 5 days earlier. You can also drop in some Avastin. You can give an Avastin injection if you find a lot of flat neovascularization after your surgery. ILM peeling, PFCL, these issues along with tamponade as discussed. So thank you very much. It's been a pleasure.
Thank you, Anand, for wonderful concept and videos. But believe me, diabetic vitrectomy is one thing where I do not go with a preset mind, because all your plans can go haywire. A simple looking job can become time consuming. But wonderful to see all your videos, and you see outside in, inside out. So these are all terms which once you are doing surgery, they go for a 6. because you can't in such situations go for a pre-plan. So wherever there is a plane found, wherever there is a weak area, weak adherence, you start dissecting in that area, because aim is to maximize the results with minimal possible complications.
Absolutely.
Any comments from others? Vishal?
No, sir, I totally agree with him, but I just I incline towards the cutter-based approach. So I'm in that group which believe that cutter can do everything. So I don't know.
Yeah, but do you do
The beveled ones.
what about bimanual? Because there are situations where bimanual.
Very rarely, sir. Very rarely. But 90% of the surgeries, the cutter alone can suffice for me at least.
You see, a couple of times I have been caught in a situation. Suppose I'm operating left eye and nasal huge fraction. I don't want to leave it, so I have to shift my, all the inferior cannula to upper nasal quadrant and then shift the microscope. Something what I call positional kind of vitrectomy. Or do you do such things? Anand,
So never faced that situation.
No, ambidextrosity is required. Obviously, one would not be doing a vitrectomy with the left hand.
I use my left hand, sir, for that.
Yeah, so that's what I agree with that. I mean, but given the bevel cutters, as Vishal said, again, most of the time you're able to get away with a lot of unimanual. But in certain situations, especially when you have very stiff retinas, sometimes you give a Avastin patient comes instead of 3 to 5 days, 2 weeks later, the underlying retina is atrophic. You want to avoid those breaks. Sometimes you also want to shorten your surgery. So I think it's important to have these scissors also in your armamentarium as a backup.
Ajay,
in a tabletop RD, my threshold for conversion to bimanual, if I feel that if the price is a break, I would rather change to bimanual and do a comfortable surgery.
Ajay, any comments? Ajay? Dr. Ajay Pal?
Yours is muted, sir.
Ajay is muted. Nice presentation, Dr. Anand. Two things I want to ask. Why do you prefer laser in place of diathermy to stop the bleeder?
So what I said was that, diathermy, it can cause sometimes uncontrolled, it can even lead to breaks. I said you can do both, but if there are small pinheads, a small focus laser will do the job just as well.
Yeah, I agree. As Steve Charles always used to say, never use diathermy.
I won't say never use it. What I'd say is avoid using it when you suspect very ischemic, thinned out atrophic retina.
Yeah, totally agree with you, sir.
Suddenly break off.
Okay, any words of wisdom from Dr. Hassan Motada, or we move on to the next?
Excellent presentation, Anand. But I think, as Vishal said, in 90% you can do the surgery with the probe, but sometimes the epicenters are too close to each other that you cannot introduce or insinuate the probe to cut between the epicenters, and in this case you have to go with the bimanual. Also, if the underlying retina is ischemic, atrophic, then I think the bimanual also decreases the instance of iatrogenic retinal breaks. So I think whether to do bimanual or unimanual depends on how the epicenter are close to each other, and so sometimes in broad sheets the epicenters are distant from each other, and you can do the job with the probe, and there is no need for bimanual.
Absolutely. You see, there are situations, bimanual meaning the eye is not dead. You see, you have to have recourse for bimanual where, it is very, very adherent and it's very difficult to find a plane. So maybe 5-10%, but definitely yes.
So that would also be around there.
Yeah.
So we cannot say that there is no place for the bimanual. No, there is a place for the bimanual.
No, Vishal is a very daring and great surgeon. He's a very great surgeon. He, I think, manages.
I know that.
Shubhendu, Boral, and all these people are young, great people doing very well with the unimanual only. We are old people. We somehow have low threshold for conversion to bimanual.